Hi, my name is Daniel Amonte. I'm an assistant professor at the UMass Chan Medical School in Worcester, Massachusetts. In this video, I'll be walking through each section of my poster titled Assessing Feasibility of a Diabetes Mellitus Program Using Behavioral Economics to Optimize Outreach and Self-Managed Support with Technology, or the DM Boost program. This poster will be presented at the 2023 Scientific Sessions of the American Diabetes Association in San Diego, California. The background of this project is that we know that diabetes self-management training, also known as diabetes self-management education and support, improves outcomes for all patients with diabetes. Unfortunately, we also know that patient engagement with diabetes self-management training is suboptimal, despite it being a recommended guideline of care for all patients with diabetes. To address this problem, we convened a patient research expert panel, or PrEP team, to co-develop the DM Boost intervention. The objectives of the DM Boost intervention are to enhance patient engagement and improve their experience with diabetes self-management training. To develop DM Boost, we deployed a user-centered design approach with the assistance of the patient research expert panel. First, to understand the context about why patients do or do not complete DSMT, we had our patient panel participate in a group meeting called a Community Engagement Studio, or CE Studio. During the CE Studio, we learned directly from our patients what their barriers and facilitators were to completing DSMT. And at the end of the CE Studio, we had a list of recommendations from the patient panel on how we can increase patient engagement and improve their experience with DSMT. Next, we met individually with each patient from the panel to gain further insights and input on proposed intervention components. From the input collected during the individual sessions, we then designed the intervention components, and lastly, had the patient panel usability test the intervention and provide feedback to inform final revisions prior to conducting a randomized feasibility pilot. For the feasibility pilot, we targeted recruiting 60 patients with type 2 diabetes who were receiving primary care at our large academic healthcare system, and who also had an HbA1c percentage greater than 8.0 in the previous 12 months and who had not previously completed education. These 60 patients enrolled in the feasibility pilot were randomized 1-to-1 to 2 different treatment groups, either a usual care comparison group who received assistance obtaining a DSMT referral from their PCP and were offered support scheduling DSMT, or the intervention group, who also received the intervention components that will be described in the next slide. Data collection was conducted at baseline and at a 3-month follow-up period, with the primary outcome being DSMT completion rate, which were collected through the EHR system, and secondary outcomes of diabetes self-efficacy and treatment satisfaction collected through baseline and follow-up questionnaires. Chi-square tests and t-tests were used to examine within and between group differences in these primary and secondary outcomes. There are 3 key intervention components to the DM Boost program. The first is an active choice invitation, which invites patients to complete DSMT and enroll in the accompanying study. Information in the invitations were developed with direct input from the patient panel and included a letter that was co-signed by the Diabetes Center Director and the PI of the project, myself, as well as a map of where the Diabetes Center was located on campus and a picture of the building so that patients would know where it was located on our large and expanding medical center campus. In addition to several options for the patients to say that they were interested in completing DSMT and the accompanying study, there was also one option for the patients to opt out of being contacted, as well as a notification that if they did not mail the invitation back, they would be called by a study team member to assess their interest. After patients enrolled in the study, they were randomized to either the comparison or the intervention group, with the intervention group participants then receiving text messages with peer tips and goal-setting nudges. These text messages were written by the patient panel to provide tips on diabetes self-care behaviors, followed by the nudge to reply to the text with personalized information related to each behavior. The last intervention component was called a telehealth training session that was conducted with my research staff over Zoom with patients. Prior to the training, my study staff would confirm that each participant has signed up for the MyChart patient portal and then would review key functionality of the portal with them. Next, they would review responses from the text messaging program and help each patient set a personalized SMART goal. The telehealth training then ended with the patient receiving a MyChart message from the study team with the goal that they had set and confirmation from the patient that they would then send a MyChart message with the goal that they set to the educator that they were scheduled to meet with prior to their appointment. To recruit our target of 60 patients, we sent out 460 active choice invitations. We then randomized to intervention and comparison group, followed them through their DSMT appointment, and a follow-up visit where we conducted a survey and semi-structured interview. The study population, the mean age of the study population was about 45, 46 years old, with a majority being female and being white or Caucasian. We saw that 30 to 37% were Hispanic Latino, with majority of patients completing either high school or college. We saw a wide range of household incomes, with a baseline A1C percentage ranging from 9.7 to 10.4% between the two groups. In regards to intervention engagement, we saw that only 4% of active choice invitations were returned. Of those 20 returned, 17 were declared that they were interested in the program, compared to only 3 that declared that they were not interested and wanted to be opted out from the recruitment phone call. After the recruitment phone call, we were successfully able to reach 52% of the patients. Amongst those that were reached, 54% were not interested in the DSMT or the study, 27% were interested in both, 14% were ineligible, mostly due to previously completing DSMT, and only 5% were interested in only DSMT and not the accompanying study. This led to a total enrollment rate of about 13%, which was higher than our target of 10%. In regards to the intervention participants' engagement with the peer tips and goal-setting nudges, not every intervention participant received the text message program. This was due to some participants received a DSMT appointment right away, and so the intervention was not able to deliver the text messages prior to their appointment. Amongst those who did receive the peer tips and goal-setting nudges, 60% responded with at least one of the goal-setting nudges. 87% of intervention participants completed the telehealth training, with 100% of those saying that the call was helpful. Interestingly, amongst those who completed the telehealth training, 85% had previously used MyChart for purposes including managing their medications, managing their appointments, messaging the providers, and viewing their test and lab results. Of those who completed the telehealth training, 80% went on to send the goal to their educator prior to their appointment via MyChart message. In regards to our primary outcome, DSMT completion, and secondary patient report outcomes, we saw that DSMT, for our primary outcome, completion of DSMT, we saw significant differences between groups, with 90% of the intervention group completing DSMT compared to only 53% of the comparison group, with 33% of the comparison group no-show canceling their appointment and 14% never scheduling an appointment. For secondary outcomes, we saw that the intervention group participants reported greater improvement in diabetes self-efficacy compared to comparison group participants. In particular, intervention group participants reported significantly greater improvements in being able to turn their diabetes goal into a workable plan and finding ways to feel better about living with diabetes. In regards to treatment satisfaction, we found that both groups had high treatment satisfaction at baseline, with no differences in change in treatment satisfaction between groups at the follow-up visit. In conclusion, we found that pilot testing the DM-Boost program was feasible and associated with increased patient engagement with DSMT and improved self-efficacy. Some unexpected system-level barriers were identified, including challenges in obtaining referrals from PCPs and scheduling DSMT appointments. These barriers were identified and will be addressed in future iterations of the program. Future research efforts include cultural adaptation of the DM Boost program for Spanish-speaking Latinx patients, further intervention refinement, and formal implementation evaluation. Lastly, I'd like to acknowledge that this work is funded in part by my NCATS KL2 award and my NIDDK KO1 award, and really would not be possible without the contributions of the DM Boost Patient Research Expert Panel, which I sincerely thank. Thank you all for watching. My email address is here. I welcome any feedback or comments, or you could follow me on Twitter at DJ Amonte. Thank you and take care.